Okay,
So here is the
quick and dirty lecture.
There's very few drugs. The one thing about
find that it's
ophthalmic medications is very few systemic drugs.
because
You've probably seen a lot of these drugs before.
Can cross the blood-eye barrier and reach therapeutic levels in eye tissue. So a lot of these drugs we're going to see are topical. There's very few that are going to be used for systemic. So for the purposes of for what we're going to do, we're just going to basically look at those medications that are applied topically. You probably applied a lot of them already so far, all the way into semester 3. The advantage of having a topical medication here are the advantages of local or topical administrations when we are speaking about, and we haven't talked about a lot, even through semester 2, about topical medications, but in the eye it's pretty much where we get a lot of the get a lot of its benefits, and there are 4 main things that a topical medication does for us, and when we can give it directly to the site of action, which means that it's not going to it is going to have very little effects on other tissues throughout the body. Its effect is more immediate because you don't have to wait for it to go through what have we been talking about all the way from semester 1? It has to go through the first past effect if it's oral, and it goes through the liver and blah 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 blah. No, it just doesn't do that. It just goes straight to where you want it to go. It's very targeted in its approach. And the other thing with this is because you can do that, you can use smaller doses. And the systemic effects, there's very little leaching of these medications into the systemic circulation, so we see very few systemic effects with using topical medications, and in particular with the eye drugs. Now, here's some routes that we have to think of when we are giving a local medication or topical. Topical is going to be directly to the surface of the eye. Periocular, okay, so this is a little bit different. This is placed along the internal, it's placed alongside the external to the eyeball, so basically almost like applying it under the eyelid. Intraocular, you're not going to be doing this. Okay, this is for an eye doctor to do, but we want to make sure you know the difference between intraocular, periocular, and topical. A RN is probably going to be doing these two. Unlikely that you're going to be actually injecting drugs into the eye. That will be for the eye doctor. So drugs, when we talk about intraocular, they're just distilled either into the anterior chamber, usually by injection, or by another injection into the intravitreal, via an intravitreal injection. So what we have right now is we have the different classes. Now look at these. Don't freak out on me already, alright? We have anti-glaucoma drugs and anesthetics. These are the only 2 ones that you have not been exposed to already through semester 1 and semester 2. Okay, through semester 2 and semester 3. Look at what we got here. Ignore the first 2 for a second. Antihistamines, we talked about that in semester 2. Mast cell stabilizers, that's part of those like leukotriene modifiers and crap like that and stuff like this. Okay, so mast cell stabilizers, those sort of things you've already talked about. You've already talked about antimicrobials. You've already talked about steroids, and you've already talked about NSAIDs. Just apply these to the eyeball. Okay, these are the only 2 things up here which are brand new in this lecture: anti-glaucoma drugs and anesthetics. So guess we're going to spend most of our time on anti-glaucoma drugs. So there are 3 different classes of drugs, and it's what they actually do. And yes, you will need to know these terms for a test, okay? Because the doctors actually refer to these as, oh look, there's even something in here that we have actually seen before. But we have these things called mitotics. They will have a mitotic action. So a doctor in an office might say, I need one of the mitotics, please give me this one. Okay, you got to know what he's talking about. Then there's another one called midratics. And then there's some other ones that sort of fall in here. And oh, there's a couple of words in there that I think we've seen before too. So, miotics, a cholinergic drug. They're going to have cholinergic effects. Oh, we've heard this before. Okay, and we're going to use the same sort of, these drugs will have the same sort of mechanism of actions as when you talked about my cholinergic drugs before. They'll either replace the cholinergic substance that you want in there, or they will block a specific receptor that will induce a cholinergic reaction. Okay, The mydratics, we're talking about an adrenergic reaction as opposed to a cholinergic reaction. And then we have some other ones that are work against adrenergics. We have this thing called carbonic anhydrase inhibitors. We mentioned at the end of semester 2, and where they're popping up here again. And we also have osmotic diuretics. Guess what? It's going to work the same way as an osmotic did in semester 2. And this other thing called a prostaglandin antagonist. Okay, so talking about this group of drug called mitotics, basically, and look, I've even put up here what these two drugs do. The miotics that we're talking about here are replacing a cholinergic drug. Okay, so we have pilocarpamine, carpinol. These, and what they do is, and this is where you have to go and you actually have to look up the anatomy of the eyeball. All right, if you don't know these terms, you got to look up the anatomy of the eyeball. Maybe have a little, while you're doing this lecture, have a little chart in front of you with the anatomy of the eyeball on it, so you can just look to it as I'm talking about it. So this will increase the outflow of the aqueous humor in glaucoma patients. So the aqueous humor is basically, when think about aqueous, it's a fluid. Okay, and what we're doing is there's an outflow that we're going to have happen here, and what will happen is we activate the cholinergic receptors to produce a dilation of this thing called a trabecular meshwork. When you dilate this trabecular meshwork, you will have fluid easily flow through it. So it causes a reabsorption of all of the fluid that is in the eyeball, and what this means is what that leads to, that's what this little arrow means, a reabsorption of aqueous humor, little arrow means leads to a decrease in IOP. IOP is intraocular pressure. Okay, you have too much fluid in the eyeball, you have too much pressure in the eyeball, not good. Okay, so this will cause this meshwork that is responsible for the regulation of fluid in and out of the eyeball to dilate. Okay, causes a dilation of the trabecular meshwork, which then allows fluid to exit the eyeball. Okay, will get reabsorbed back into the system. This is simple. The problem with this drug is it may produce psychoplasia, and what is basically means blurry vision, and it will cause some accommodation effects. Accommodation is the ability for you to focus quickly. Okay. The other drug that is a miotic, that is a blocking drug, are these things called cholinesterase inhibitors. Okay. And pretty much there is this one here called physostigmate salicylate, which is almost like maybe it's related to a ASA. It produces the same effect as the direct action agents that we talked about on the previous slide, but what it does is it actually blocks ACH breakdown, because this is happening in your eyeball like it happens everywhere else. ACH, which is one of the major cholinergic neurotransmitters, is released. It gets broken down and it gets removed, and it gets released and broken down and removed, released, and it's a constant flow like that. If we want more of it to be produced, we could stop it from being broken down, and guess what? Same thing happens. The trabecular meshwork expands, and the aqueous humor flows out, and you get the same effect as you did on the previous slide. All right, so that was it. Two slides, easy peasy. On to the next one here. We're going on to these adrenergics, or these mydratics, okay, or mydriatics. And we have, oh, look, an olipine, and this other one called afigan. So look at pine. There's a dene on each one of these. Denes are mydratics. So the denes here are, there's this thing called an alpha-2 adrenergic agonist used to treat open-angle glaucoma and what we call ocular hypertension. Again, too much pressure building up in the eyeball. And these mimic the sympathetic neurotransmitters of epinephrine and norepinephrine. They cause the pupil to increase, which decreases intraocular pressure. So two mechanisms of action so far that you have to take away to reduce pressure in the eyeball. You can reduce the fluid in the eyeball by having it flow out. That was on the previous two slides. Now we have a different mechanism of action here, which is dilating the pupil. Okay, if you dilate the pupil, you will also decrease intraocular pressure. Okay, there's only two ways so far. All right. So this drug here, Mydradix, mimic epinephrine, causes the pupil to dilate. That dilating pupil actually causes a decrease in intraocular pressure as well. And oh my God, there's some more. There's these anti-adrenergics. Okay, so we just talked about adrenergic. Now we're flipping right over next slide. We talk about the next one. Like I said, there's not a lot of slides in this lecture. We have this other one that's called, a beta blocker. Have we seen a beta blocker before? Yes, we have. So these ones are semester 2, in case you can't remember. It was what was a beta blocker? It was a hypertension medication. You can use beta blocker hypertension medications for your eyeball too. Amazing. So this, and by the way, if you want to remember back to semester 2, I know it was so long ago, but when you remember back to it, remember we said that beta blockers, we have to be careful when using it in what kind of patients? People with glaucoma, just in case the medication did cross the eye-brain barrier. We did say it's very difficult to do. That's why I used it with caution when you used a beta blocker for hypertension. You used it with caution because some of it might flow across. It doesn't easily flow across the eye-brain barrier, but some of it might. Use it with caution to make sure you're not causing issues. So an anti-adrenergic or a beta blocker, okay, it is a selective blocker indicating for open-angle glaucoma and ocular hypertension. So we have to be careful here, okay. Open-angle glaucoma is different than the previous ones. So yes, you will see probably on a test open-angle versus non-open-angle glaucoma. You have to differentiate between the two. Don't screw those up. So we have this one called Bexatol, which is used for it. We have this other one called Timidol. It's indicated for elevated IOP and intraocular hypertension. Beta blockers do not, and this is where beta blockers are different. They do not play around with the pupil at all or produce cytopletic effects. So which is why this is kind of a good medication, right? Because so far up to now we've had, one medication which is going to do what? Cause blurry vision. Yeah, great, I don't have glaucoma, but I can't see where the F I'm going. And I'm going to bump into everything because I have blurry vision and I can't accommodate very quickly. The other one, it's going to dilate your pupil. You've gone to the doctor's office, your eye doctor's office, at least once in your life, and they put the drops in your eyes that dilated your pupil. That was the crap on the last couple of slides, okay, the Mydradix. This one here, decreases the intraocular tension and ocular hypertension without the two nasty things we talked about in the previous slides. So this is a good thing. And a patient who cannot use beta blockers or use carbonic anhydrase inhibitors, okay, you use it on somebody who cannot use these or the diuretics or any other alternative. So if you've used everything else, nothing else sort of works, okay, you go to these medications. These are generally not high enough to cause any circulatory effects because, as we said, this is a topical medication, so it's not going to actually easily go into the bloodstream. So we see that this is a very useful drug, okay, and it's pretty much our last ditch drug that we would use if nothing else happens. But it's got some very nice lack of adverse effects that we've seen so far with the other drugs. All right, carbonic anhydrase inhibitors. Okay, look, what's the commonality in here? Mide, mean, these are mean drugs, okay? Don't mind them, they're mean drugs. Carbonic anhydrase inhibitors. They do the same, they decrease now this one is, different mechanism of action. You might want to so far make a little chart for yourself and what the different mechanisms of action are. Just list the category and what each one does, okay? Because now we've come to a different mechanism of action right here. What's this one doing here? This one doesn't, so far we've talked about miotics, increasing outflow of fluid. We talked about the Mydradix, which was dilation of the pupil. Now we come to this garbage right here, and what it is doing, it is reducing the production of fluid in the eyeball. There's not a lot here for you to remember, and it will get you a lot of marks if you just differentiate between those ones. So it reduces the production of the aqueous humor, It decreases the intraocular pressure in glaucoma patients. It sort of has a diuretic effect. It's the second choice if beta blockers are contraindicated or not effective. So we got one thing over and above the beta blockers. If something else doesn't work, then you can use this junk right here. More effective than when used to treat what we call open-angle glaucoma. And the only problem with this one is if you have an allergy to sulfonamides, this is the only big downfall of this drug. If you are allergic to sulfa medications, you cannot take this drug. There's going to be a risk of an allergic reaction. Osmotics. These are nice. This is a nice, easy one, right? It's an osmotic agent, which means it's an agent that is a very concentrated agent. And what it basically does is a concentrated agent. It draws fluid out from your eye, from the inside of the eye, and increases osmotic pressure. Okay, it doesn't screw around with any production. It doesn't screw around with the pupil. It doesn't screw around with that trabecular network. What this basically does is it's like putting a Kleenex between a pile of salt and water, and what ends up happening if the two touch the Kleenex in the middle, then what's going to happen is the water is going to be sucked across the Kleenex. Okay, that would be your eye membrane into the salt, right? So if we have a very concentrated concentrated medication that has a high osmotic property to it, then what it will do is it will draw fluid that is of a lower concentration to it. And that's where we get this reduced intraocular pressure by reducing the volume. Okay? Changes, and what we say in more definitive ways, we say it changes the concentration gradient that draws fluid from the vitreous humor. Prostaglandin analog, meaning it's like a prostaglandin. Okay, it's the first-line agent for glaucoma patients who do not respond to beta blockers, and then so we have something. So if you don't respond to beta blockers, then we move to these things called the prostaglandin analog, and then you would hopefully then move, you could, to the carbonic anhydrase inhibitors. But right now you see that, hey, I think the beta blockers are something that we would use first line, right? And the adverse effect of these ones basically, oh, look what they do. They reduce congestion in the trabecular network. So these kind of work a little bit like the, which one? Myotics or myotics? I can't remember. Myotics. They work like the myotics, okay? They reduce the congestion in the trabecular network, so it draws stuff out as well. And the adverse effect from there is, well, you see, unfortunately, I'm not sure I'd want to use this medication as my first choice, okay? It has some very interesting things. The very interesting things here are just, it will make your pupil more brown, okay? And it will also cause that cytoplegia, so it's going to cause that blurriness. It can also cause some irritation. So we're back to the things that we didn't want in the first place, okay? But nothing else works. Yeah, you got to try something, okay? All right, that was the anti-glaucoma drugs. I would strongly suggest making a little chart, putting the name of the medication, putting the not the main name first. I would put in the first column, I would put the category of the medication. Is it a myotic? Is it a mydriatic? Is it a blah, 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 blah. Second column, I would put the names of those medications. Third column, I would put the mechanism of action. In the fourth column, I would put the nasty things that can happen with each one. You do that, stick that on your wall, look at it once a day when you're walking through, when you're studying for other stuff. You're probably going to get them all right on the test. All right. So, ophthalmic drugs, anesthetics, local. Okay, so we've got some local anesthetics. We're talking about these antihistamines, antimicrobials, and these other ones here. Okay, anesthetics, basically to numb your eyeball. Okay, you're going to have some sort of procedure done on your eyeball. We give you an anesthetic. All right, and we have tetracaine, lidocaine, propiocaine. If it's got a cane on it, it's part of these anesthetics. And pretty much what they do is they numb the eyeball. They're used for diagnostic and other therapeutic purposes. Things like tonometry, which is doing some measurements of the eye, removing foreign bodies. I do this all the time in the emergency room. We throw some tetracaine in there. Removal of any sutures post-surgery, and if they're doing minor eye surgery as well. They block pain by stabilizing the neuronal membranes of nerves. They stop them from actually working from actually getting excited, so they become less permeable. They do not transmit nerve impulses. Antihistamines, these are easier, so antihistamines and mast cell stabilizers, and this one is called Opticrom or Cromolon. It is an antihistamine. It blocks H1 receptor, so this is a first generation antihistamine, if you remember back to semester 2. It stabilizes those mast cells, and then it's basically used to treat itchiness and inflammation of the eye that usually comes with allergic conjunctivitis. Remember, allergic conjunctivitis, itis basically means inflammation. Antimicrobials are pretty easy. You've actually seen these ones, and guess what? You can put it in a little bottle and put it on your eyeball. So we have the sulfonamides. If you don't have as long as you don't have an allergy to it, okay? So we will see these ones right here. This is sulfonamide base, basically trained if you have a conjunctivitis that is due to a gram positive and gram negative infections. We can give you erythromycin if you unfortunately have some gonorrhea in your eyeball. Don't know how you got that in there, but you know what? You can use erythromycin for that. We also have gentamicin, tobramycin. This is pretty much what they stick in the eyeballs of children if the mother is a GBS positive, which is gram stain. They'll give it if there is a risk, of the woman actually having gonorrhea, not GBS. But actually no, I think they will. I think they do give it. You can look it up. It won't be something on a test. But gentamicin, tobramycin, and moxifloxacin are used to prevent neonatal gonorrhea, chlamydia, E. coli, wide range of infections for this as well. Note that some of the antibiotics can be combined also with steroids, so if you want to reduce the inflammation as well as get rid of the bacteria that's there, you can mix the two of them together. You can have a combination drug. Antivirals, well, guess what? You can stick some of the same drugs used as an antiviral into your eyeball. We have this one right here, one that can treat herpes. It's indoxacarine. We have trifluridine. We have vibradine, or Vibra-A. This one's used to treat a herpes infection. Most of them look at herpes. Pretty much herpes is what we use the antiviral drugs, not much else. So don't actually say that you can cure, like, the common cold or the flu or the flu virus in your eyeball. It's only for herpes. Okay, whoops, excuse me. NSAIDs. Guess what? If you don't really need a big frickin' steroid, okay, you can use a NSAID, non-sterile anti-inflammatory, okay, drug. And we see that there are some funky names here. Ketorolac is the most cool one right here because it's the one you see most often. But look at anything with a lac on it here, Difenolac, Ketorolac, okay, it's basically, and what I would say for these ones, most important, is take a close look at what it's used for, because there are some choices here. So the Suprafen is basically used to inhibit intraoperative meiosis. So when they're doing a operation, okay. This one here is used to treat post-operative inflammation after cataract surgery, okay. And Ketorolac here is pretty much used for your conjunctivitis. So you basically have one to inhibit intraoperative meiosis, so one for when you're having the operation, one for cataract surgery, and one for allergic reactions. That might pop up as something to differentiate for on a test.